Does Medicare pay for home health care? It does, and for the services it covers, you pay nothing. No deductible, no copay, no coinsurance. That comes straight off Medicare's own coverage page. It is one of very few benefits in the whole program with a price tag of 0. So why do so many families end up paying out of pocket anyway? Because Medicare and the person typing that question are usually talking about two different things. When a family searches this, they picture someone coming to the house to help mom bathe, get dressed, and make lunch. When Medicare says home health care, it means a nurse or a therapist. Those are not the same benefit, and the gap between them is where the money goes. Here is the short version. Medicare pays for skilled care at home, delivered part-time when a doctor certifies that you are homebound and that you need it. It does not pay for help with daily living when that is the only help you need. That is the answer. Now here is the part that is genuinely worth your time. The most common reason people get told no is a standard that stopped applying 13 years ago. It is still being quoted at families today. I will come back to that. First, the 4 conditions, because all 4 have to be true at once. Medicare's official booklet, the one numbered WEN 969, lists 4 requirements. 1. A doctor certifies that you are homebound. 2. You need skilled care on an intermittent basis. That means skilled nursing, physical therapy, speech-language pathology, or continuing occupational therapy. 3. A doctor, nurse practitioner, or physician assistant certifies that need after a face-to-face encounter with you, not a phone call about you. An actual visit. 4. The care comes from a home health agency that Medicare has certified. Miss any one of those and the answer is no, however much help the household genuinely needs. Notice what is not on that list. Your age is not on it, your income is not on it, and despite what a lot of people believe, a hospital stay is not on it either. More on that one shortly. 2 of these 4 are where nearly all the confusion lives. Let us take them in order. Start with homebound, because I think this one word costs more people the benefit than anything else in the program. A home health nurse left a comment under one of the top videos on this topic, and it stopped me. She said that when she went out to sign patients up, several of them refused the care outright once she explained homebound status. They believed it meant they could never leave the house again. They would rather keep their weekly dinner out. They gave up the benefit for no reason at all, because homebound does not mean housebound. Medicare's coverage page says leaving home has to take a major effort or help from another person or a device. And then it says, in plain language, that you can still leave. You can leave for medical treatment as often as you need to. You can leave for adult day care. And you can take what Medicare calls brief and infrequent trips for other reasons. The examples the government itself prints are a haircut, a religious service, and a family event such as a birthday party. Going to your grandson's birthday does not end your coverage. Medicare wrote that down. So who actually turns up at the door? Medicare lists intermittent skilled nursing care, and it specifically rules out visits that exist only to draw blood, physical therapy, speech-language pathology services, continuing occupational therapy, medical social services, which is the caseworker who handles the practical and emotional side of an illness, certain medical supplies, and injectable osteoporosis drugs. Intermittent has a defined meaning here, and it is stricter than it sounds. Medicare's booklet puts it at fewer than 8 hours a day and 28 or fewer hours a week, reaching 35 in some circumstances. Needed at least once every 60 days and at most once a day for up to 3 weeks. So this is a nurse for an hour, a few times a week. It is not a shift. One cost note, because there is one. Medicare's own equipment publication says the covered home health services run at 0. Durable medical equipment is billed separately. That one runs at 20% of the Medicare approved amount, once the Part B deductible is met. The nurse is free, the wheelchair is not. And there is one more item on the covered list. It is the one families care about most, and it is the one with a catch. That item is the home health aide, a real person Coming to the house, helping with bathing and dressing and getting to the bathroom, Medicare does cover it, part-time. But look at the condition attached, because it is easy to skim past. Medicare covers the aid only if you are also receiving skilled nursing care, physical therapy, speech-language pathology services, or occupational therapy at the same time. The aid rides along with the skilled care. It is not a benefit that stands on its own, which means when the nurse's orders end, the aid ends with them. Somebody asked exactly this in a comment thread and never got an answer. How do aid agencies get paid by Medicare for help with activities of daily living? Mostly, they do not. They get paid while a nurse or a therapist is still on the case. That is the trade at the center of this entire benefit. Which brings us to the list nobody quotes often enough. Medicare's booklet spells out what it will not pay for, and it is short enough to read out loud. 24-hour-a-day care at home. Meals delivered to your home. Homemaker services, meaning shopping, cleaning and laundry, and custodial or personal care, which Medicare defines as bathing, dressing and using the bathroom when that is the only care you need. That last clause is the whole ball game. Those same tasks are covered when a nurse is also visiting and not covered when nobody is. Same task, same person, same house. What changes is whether skilled care is running alongside it. Someone asked under one of these videos whether the benefit covers diaper changing and bathing. Nobody answered them. Now you can see why the honest answer is that it depends entirely on what else is happening in that house. Medicare is not a long-term care program. It never was. Long-term custodial care sits mostly with Medicaid, which is run by the states and tests your income and your assets. Veterans benefits and long-term care insurance cover a smaller slice. That is how a family can lose a house to a nursing home bill while holding a Medicare card the entire time. Now, the rule I promised you. There is a belief, still repeated by some agencies and even some clinicians, that Medicare covers skilled care only while the patient is improving. Plateau and the care stops. The belief has a name. People call it the improvement standard. It is not the law. It has not been the law for 13 years. In 2013, a case called Jimmo versus Sebelius was settled against the federal government, brought by the Center for Medicare Advocacy and Vermont Legal Aid. CMS then published a fact sheet confirming the outcome in its own words. Coverage of skilled nursing and skilled therapy cannot be denied because a patient is not improving. What matters is whether the skill of a professional is genuinely needed. Where skilled care is needed to maintain someone's condition or to prevent or slow their decline, the settlement says Medicare covers it. That applies to home health, to skilled nursing facilities, and to outpatient therapy. Maintaining is enough. Not getting worse is enough. And the Center for Medicare Advocacy still publishes a self-help packet built specifically for improvement standard denials. Think about what that tells you. A standard the government agreed to drop 13 years ago. It is still used often enough to say no that somebody has to keep the instructions in print. So which part of Medicare pays for all this? Mostly Part B. Part A can cover home health after a qualifying hospital stay or after a covered skilled nursing facility stay. But the benefit itself does not require a hospital stay to exist. That distinction matters because plenty of people assume the 3-day hospital rule applies here. That rule is real, and it belongs to skilled nursing facility coverage. It is not the gate on home health. A commenter on one of the top videos laid the situation out exactly. Living alone, no family nearby, a knee replacement coming up, asking whether the length of the hospital stay would change what Medicare provided at home. Going by Medicare's published rules, the home health benefit turns on being homebound and needing skilled care certified by a doctor. The hospital stay affects which part of Medicare pays the bill. It does not decide whether the benefit is there. How long does it run? Doctors certify home health in 60-day certification periods. Inside each of those, CMS pays the agency across 2 30-day payment periods, which is a billing structure rather than a countdown on anybody's care. And 60 days is not an expiry date. It is a recertification cycle. As long as a doctor recertifies and the conditions still hold, it renews. Put that next to the GIMO settlement and you get something a lot of families never realize. Where skilled care is genuinely needed to hold someone steady, there is no built-in time limit on this benefit at all. One large caveat now, and it applies to more than half the people on Medicare today. Everything so far describes original Medicare, Parts A and B. Medicare Advantage plans have to cover the same benefits, but they are allowed to run them differently. Medicare Interactive points out the practical difference. Original Medicare rarely requires prior authorization. A Medicare Advantage plan may require the plan itself to approve home health before it starts, even when a doctor has already ordered it. The agency generally has to sit inside the plan's network as well. So the benefit reads the same on paper, and the road to it does not. Two people on the same street, same diagnosis, same doctor's order can have completely different experiences depending on which card is in the wallet. Last piece, and it is the one people are least ready for. Sometimes the care stops before the family expects it to. When an agency reduces or ends services for its own business reasons, CMS requires it to hand over a written notice. It is called a home health change of care notice, and in some situations an advance beneficiary notice. That notice matters because in original Medicare it carries a right to a fast appeal to an outside reviewer called a Quality Improvement Organization. Medicare Interactive states the deadline plainly. The QIO has to be contacted by no later than noon of the day after the notice is received. Noon the next day. That is a very short window. Printed on a form that gets handed to somebody who is already having the worst week of their year. And which agencies nearby has Medicare actually certified? Medicare publishes that list itself. In the Care Compare directory on medicare.gov, it carries star ratings. So here it is. Medicare pays in full for skilled part-time care at home for someone a doctor certifies as homebound. It does not pay for daily living help on its own, however badly that help is needed. Knowing exactly where that line falls is worth real money. Two things push families onto the wrong side of it more than anything else. A single word they misunderstood, and a rule that stopped being true in 2013. I would like to know which one caught you. Has an agency ever told you or someone in your family that the coverage was ending because the patient had stopped improving? Tell me in the comments. I read them.